Hello, good afternoon, Mr. Chairman, Dr. Gold, Dr. Bell. I am very happy to be here again in AIMS after this fantastic experience that I had working with you in the cath lab in the past. So, ladies and gentlemen, dear colleagues, I will try to summarize the history of what we call TAVI, T-A-V-I, for transcatheter aortic valve replacement, and a technique which is relatively new in India, so I think that very little of you know something about it. So I will do it in French as usual. J'ai eu le plaisir de travailler pendant des années.
I have the pleasure of working with most of the government hospitals, also private clinics, and during this period I have been able to do some innovations with for aortic dilation valve. The mitral stenosis was done in 1997. I am not in a position still to get the result in India through the transcatheter method. I am going to point out that during these developments, I have worked a lot with India for developing the mitral stenosis. The first case by using this method in Apollo Hospital, Hyderabad, mitral commission. With regard to the innovation, there is a direct relation between the treatment of calcific aortic stenosis with the artificial valve, which is just a prolongation, extension of the initial technique. As I said, since 1990, we have had several exchanges with India, and a lot of heart specialists were trained by this Indo-French Foundation, and we had the possibility of creating the Indo-French Foundation of heart specialists, which allowed me to discover India, especially a large number of colleagues whom I met and with whom I have an excellent relationship. In India, it's not a disease which is rather known. It is more of a Western disease. In Europe and United States, it is really very frequent, and more than 5 to 7% of people are affected by this. As you can see, this valve, aortic valve, which does not open properly. So this is a terrible aspect, and if we don't do it, if the calcification continues, within 2 to 3 years, 80% of people may die. So therefore, an immediate action is required. So why we have developed an interventional technique that we developed? The replacement of the surgical valve, which has been the standard care for decades, and that, as you can see, the degenerated valve that was not working by implanting an artificial implant, and that allowed to lower the mortality rate and also enabled the patients to go back to their normal life expectancy. So many of these patients are not operated upon, and an important work has been done in 1994 where 1/3 of the patients had to be operated but was not done. So it is important to think about before 1985 there was a possibility of the balloon aortic valvoplasty, And what was done by surgeon, as you can see, this technique, it was done once again quite a few times by our team, comprising of the names that you can see here, with tens of thousands of patients have been treated through this balloon aortic valvoplasty, and for which there was no surgical intervention was required. There are other implications, so we had to do something. This is the usual observation during the BAV. So you can see the balloon that has been inflated. Whatever the amount of calcium inside, we can put a stent in the middle of the balloon so that we can open up the valve. We had to also think about a particular structure of the valve, and there we came up with this combination of the balloon technology and conceiving a model. So here you can see with the stent, you can see the structure of this valve. So this is the first model of the valve which was developed by our heart specialist, which looks to the design that I just not showed you. During 5 years, that is 94 to 99, we submitted the project and the reports were rather negative, technically impossible, clinically dangerous, and the most crazy project. And therefore the people, the companies, and they just said that forget it. And the Indian companies were no different also. So it was important for us to start a startup with colleagues in United States, and it was possible to develop a tri-leaflet bovine pericardial valve in stainless steel, which you can see. And this valve was developed in the laboratory, and it was put in test in a ship. And here you can see how the valve is functioning in the laboratory, and the result was highly encouraging. In April 2002, we were able to put it for the first time in a human being, a person who was 57 years old, who had cardiogenic problems, multiple comorbidity, intraventricular problems, and several episodes of cardiac episode. So you can see in the graphic presentation here, the first valve. This is here you can see the aortic valve is here. So the atmosphere was rather tense during the first implantation of this valve. For the first time it was put in a human body, and the result was very good. And you can see the eyes of my colleague, and immediately after the procedure, and within a week's time the person was more or less cured. In 2004, once again, 40 other cases have been performed by us in Rouen, where new valves were developed. The Edwards Life Sciences company, which is an American company that helped us to build this valve, design this valve, and also manufacture this valve. And they were able to produce valves of high quality of 23 and 26 millimeter. So here you can see in this graphic presentation that how the valve was inserted inside. This was in Vancouver for a patient for which other measures were not possible. This is the valve which has been inserted, the Edwards Sapien valve, and a large number of studies have been carried out, the feasibility study in Europe and as well as in Canada, till we worked out a partner study along with a randomized trial along with an American partner in order to develop this technology. So with a partner, this was involved 1,057 patients and patients on which the surgical intervention surgery was not possible, and out of which 699 were in the high risk factor. And we did a comparative study, and this is once again a slide which is depicting you the result, which were excellent, and they were published in October 2010 in Martin and Leon and also in June 2001 by Craig and Smith. So New England Journal and of Medicine. So there have been 25% reduction in the mortality rate. So this has been TAVI, as you can, has become a valid alternative to AVR in high risk patients, and you have realized that after 1 year the mortality and the result they can be superimposed one on the top of the other, which is on the right hand side on the top side of the presentation. So these two techniques enabled to improve the quality. The other valve was developed after a little bit after us, and it was based on an automatic deployment of a mechanism which is completely different to say, especially for high risk patients, and which enable to bring down the mortality rate to a considerable rate. And this was, of course, was extremely encouraging. This is the roadmap that you can see right from 985 when you start this balloon aortic valve intervention, and then 2000, 2002, 2000 involved animal implantation. Then 2002, as I told you, was the first intervention on human beings, and then gradually 2000, and finally this study which was carried out along with the partner, which I just mentioned, with the American partners in October 2012, especially with the patient with high risk. And this was also published in the reviews in 2014. And it's very important to talk about this French innovation. Simultaneously, a core valve that was developed. So a pivotal US study, FDA 2014, was carried out, registry, CE mark, FAMx, especially for high-risk patients. So there has been a long way we have been walking on, we have been traveling, and we have known today very important extension of this technology all across the globe. As you can see, 200,000 TAVI procedures have been done. This is the world distribution of TAVI as now available, and 65 countries around the world they are in fact using this TAVI regularly. In India, which just received the authorization of the government to start the TAVI, we are going to do the first implantation beginning next year. The example in France, 6,000 TAVI per year, and in Germany 8,000 TAVI per year. So between 5 to 9 TAVI that we do everywhere. So this is the graphic representation, the curve. So 71,000 patients in 2015, and 150,000 patients we will count around 2020. So therefore the situation demands an action. In Europe, this is the implantation of TAVI. It's a large number of implantation in Germany, Switzerland, Austria, France, which was the initiator of this project, United States, Netherlands, and then gradually the TAVI implantation goes down. and underutilization of TAVI depends on the reimbursement of the procedure. 50% of patients of AS remain there. So India is well placed to take up this challenge. This is the current guideline for freezing TAVI, ESC guidelines 2012. It is generally prescribed for high risk and non-operable patients, and there is a group of doctors, heart specialists, who are part of the heart team. In fact, they are working together, and the decision must be taken by this heart team, taking into considerations all the aspects related to this. In fact, in reality, we see that right from 1994, between 2002-4, when the first valve was implanted, in fact, 2005, between 2005 and 9, that we see that the surgical intervention, the surgery has gone down for 75% of the patients, and the last model, we can say that it has gone down by 55 to 60%, and that the rest can be treated by TAVI. So our valves are not the only ones to have contributed to the progress. In 2004 we have started. Next year we are going to bring this technology to India, and this may be developed by other companies also. So these are the latest models of the valve, Edwards valves, which is known as Sapien 3 valve, and then core valve. So here we can see that we are implanting one valve, and it is how it is put and then how it is inflated, and Sapien 3, and the results are excellent. So, and also this valve has enabled to reduce the stent-like procedure, especially in comparison with the surgical intervention, which has been minimalist. Conscious sedation, local anesthesia, no TEE, then pre-colleagues with ProStar XL, and duration of the procedure is only 45 minutes, and the patient is discharged within 1 to 3 days, and especially for 60% cases within 3 days. So that has really revolutionized the way we have been treating this particular syndrome. Here we have a patient who is 101 years old and who has been put Sapien 3 in May 2015. No local anesthesia, no complication, back home right at the day 1. And Friday she came, and within 24 hours she went back home on her foot, walking without anybody accompanying her, and this is just to show that how well it was done. So here one can say the mortality rate has really gone down. This has been a problem, this hole in the valve, and that created a great deal of mortality, and that has been reduced to a great this is the spontaneous evolution of the disease, expansion of the degenerated of the bioimplant. For instance, in India, the patients do not accept to be operated upon for the second time. We have 2,200 patients on which a valve has been implanted, and with that we have the experience, we know how to do it. In 2005, TAVI is indicated and not optimal, also for not optimal, and in 2025, SAVR is indicated and also for not optimal candidate. So this is the current stage, and I thank you very much. The conclusion, I think TAVI is really a breakthrough technology with significant and positive socio-economic consequences. In 2015, TAVI is entering a new phase of technology enhancements leading to improvement of outcomes. And I think in 5 years to come, the impact will continue to grow in the next couple of years. This will be the default strategy for AS patients, and SAVR remaining as the suboptimal for TAVI indications. Thank you for your kind attention.
Poser une question. Quel est le rapport en France du coût comparé de la valve implantée par voie artérielle et de la chirurgie?
Alors en France, actuellement, les deux coûts sont à égalité. C'est-à-dire que la valve n'est pas plus chère, mais moins chère que la chirurgie cardiaque. Ça a été montré notamment par l'étude économique France 2. I'm sorry, I think I should speak English, but it was about the difference of cost between surgery and TAVI, and just to say that today in Europe and in the United States, the price of TAVI and surgery are quite comparable. And we have the feeling that the cost of the procedure will decrease with more experience, with more competition, with other technologies, and with the fact that the R&D expenses will continue to decrease with time. So I think that, as a matter of fact, the TAVI might become less expensive, but it's not the case in India.
Yeah, actually, sorry. I'm Dr. Vivek Gupta. I'm cardiologist in Apollo Hospital, Delhi, and it's my privilege that I'm here with Dr. Behel and Dr. Alain Cribier. It's rather not a question but a comment, because a lot of people are maybe not actually physicians here, but they should know. Professor Alain Cribier, what he has created, this is one of the major breakthrough. It is basically a non-surgical treatment or replacement of the aortic valve. And he started this procedure when I was working with him in 1996. At that time, it was almost a passion or obsession for him to develop such technology. And then, of course, as he's told that it was 2002, April 16, when the first in-man implantation was done. And since then, more than 2 lakhs procedure. 200,000 means 2 lakhs in Indian has been done worldwide. Unfortunately, we do not have still available in India, which I think will soon have it. I should compliment Dr. Cribier that such a thing has been developed, which has been accepted all over the world. As you said, more than 65 countries have this procedure being done. Unfortunately, not in the Asian subcontinent. This being done in patients who has a severe aortic valve stenosis, where you cannot do surgical open heart surgery because of the other disease. I just want to know one question from Dr. Cribier, because he has already told that what do you think when it will be actually available or indicated for the low surgical patients?
Well, actually, there is a randomized study in the United States, which is called Partner 2 trial, which is a randomized comparison of TAVI in low-risk patients and surgery. The results will be published at the next ACC meeting in March of 2016, and I guess that probably we will show that there is no difference between TAVI and surgery in this low-risk population, and then it will be the beginning of a new era for TAVI, certainly.
And that time, I think the more exponential growth of this procedure will be there worldwide.
Yes.
Thank you.
Thank you.
Professor Cribier, it's always good to listen to you and learn. Every time I listen to you, I learn something new. Having seen you perform in several live workshops, I agree that it's as simple as an angioplasty in experienced hands, especially in your hands. And I hope it will be soon available commercially in India, though 50 odds valves have been implanted on compassionate ground.
Yes.
I think the 2 remaining problems are stroke and the complete heart block, which are in single digits, and various valves which are repositionable, and 3rd and 2nd generation are available. But I won't go into TAVI because we know that we have reached that stage. I'll just take this opportunity to listen a few words about other valves, like tricuspid pulmonary and especially the mitral, where we stand.
Yes, well, actually, first of all, stroke is no more an issue today with the new devices. So you are referring to the last generation of valves, but today it has been shown that stroke is no more an issue in comparison to surgery, for example. So this is a good sign. Now, concerning the mitral, many people are developing a mitral valve for percutaneous mitral valve replacement for the treatment of mitral regurgitation, but the problem is extremely difficult to solve because anatomically, the mitral annulus is totally different from the aortic annulus. It's extremely big. The valve is very large. We have a lot of potential complications after valve implantations, like, for example, the occlusion of the outflow tract to the aorta. So this is a real problem. There is also an issue which is the valve thrombosis. because we are in a low flow regimen, so it means that the risk of emboly remains stroke remains relatively high with this mitral valve. So we are today in different companies studying, I would say 5 or 6 different devices, and with in each company, I would say between 10 and 20 patients implanted. So it's too early to have a good idea. But also the indication is not the same, because the mitral replacement will be aimed at treating functional mitral regurgitation, not organic mitral regurgitation. Functional. It means that we will be treating the symptoms and not the disease. So I think that we have to be extremely cautious when we think about mitral valve replacement. It will not be the same story, but it will come, but it will take probably many years. Try to speed this.
Just a small information to the House that till the time we don't have TAVI available in India, Dr. Cribier himself has initiated a program where the patient can be brought to the, or sent to France, where with the limited costing, and we have done few patients from India in Rouen itself, and he has got a cost which is quite limited and helpful to the patients. If at all there's some patient who want to go and travel to France to get the process done by Professor Cribier himself in Rouen.
Okay, I hope they are doing fine.
Oh, thank you, sir.
Thank you very much.